Good morning. Good morning. Welcome everybody that's here and everybody online today. We have a special Grand Rounds. We are thrilled to bring back one of our own, one of our former residents and pediatric emergency medicine fellows. I see the PEM group here. Shout out to them. Today for Grand Rounds, and has really had such a successful career and makes us all so proud to welcome him back. So Dr. Danny Thomas is a professor of pediatrics in the section of emergency medicine at the Medical College of Wisconsin in Milwaukee, where he serves as the research director and chair of the Minimal Risk IRB for Pediatrics. His research career, as I said, began here and is defined by a commitment to advancing pediatric concussion care through pragmatic clinical trials that directly inform our patient care and challenge outdated practices. Dr. Thomas has led multiple funded studies, including collaborating with our own Dr. Bob Hickey on really seminal work that evaluated concussion recovery, as well as how we manage concussion, focusing on rest, activity, and health literacy. Danny's work has influenced national concussion guidelines and has emphasized the importance of symptom-guided and individualized recovery strategies, and you'll hear more about them today. If you've had the privilege of working with Dr. Thomas, you'll know that he is known for blending empathy, evidence, always evidence, and humor, wearing his red Converse, and Dr. Williams supporting him today wearing her red Converse, to teach in just the most empathetic way, prioritizing the human side of emergency care. As we welcome Dr. Thomas back, he expresses that he returns to Pittsburgh with deep gratitude and lasting ties to the community that helped shape his career. So let's give him a warm welcome.
All right. Thank you so much for having me. So first of all, I have no financial relationships to disclose. I will not be discussing any unapproved investigative devices unless walking is considered an exercise or device. My studies are funded by the CDC, either through Injury Research Center grants or through CDC TBI program grants. And with that, I will note that on April 1st, the CDC TBI team was let go. And with that, I also have some new disclosures for 2025. So I am an immigrant. My parents came to the U.S. under the Health Professionals Educational Assistance Act of 1976 that aimed at addressing the U.S. physician shortage. With that, I became a physician, as did my siblings, so I think that's pretty good return on investment. I'm a product of public education from elementary school through college, and I value its role in shaping knowledge and opportunity. I'm a scientist, which means that I thrive on skepticism, evidence, and the idea that facts matter, even when they're inconvenient. And this presentation may include some of the 197 words and terms currently flagged by NIH and NSF. You have been warned. All right, the objectives are to talk about the pathophysiology of concussion, to learn the acute TBI assessment paradigm, to discuss the evidence regarding rest and activity in concussion, and recognize the impact on discharge instructions on recovery, and then apply a rehab approach to guiding individualized concussion management. So I like to say I wear many hats, like the character in the very classic piece of literature, Caps for Sale. So I am the president of the medical staff at Children's right now. I lead an educational program for pre-doctoral and postdoctoral students. So some of these challenges at the NIH are very close to my heart as far as impacting my students. I'm chair of the IRB, and I also do research. And then seasonally, I play Santa. And much like the character in Caps for Sale, I'm tired a lot, and I like naps. And I'm looking forward to giving my caps to other people. My research journey started here in Pittsburgh, back when I had more hair on my head and less hair on my chin. And when I didn't need to wear orthotics to wear these red shoes. I was a community-oriented residency experience trainee, and my continuity clinic was the Child Advocacy Center. And with that, I spent a lot of time thinking about child abuse. And one of the things I was thinking about is shaken baby syndrome, an infant version of second impact syndrome. And when I was a resident, I had an opportunity to hear Mickey Collins present. and he presented on concussion, and I accosted him after the meeting and peppered him with a whole bunch of questions and left having bitten the concussion science apple and leaving a concussion scientist. So traumatic head injury is a significant injury burden in the United States. 7,000 deaths a year, 95,000 hospitalizations. Almost 500,000 kids are showing up to the ED for evaluation of traumatic brain injury or concussion. Often feels like they're showing up in our ED, but it's distributed across all the EDs. The clinical challenges that present themselves in the emergency department are managing children with moderate to severe traumatic brain injury or TBI, and that's really defined by the Glasgow Coma Scale. Identifying those children with significant intracranial injury and improving those outcomes for mild traumatic brain injury. When it comes to those severe traumatic brain injuries with a Glasgow Coma Scale of less than 12, really the goals are to prevent secondary injury. And from the ED perspective, there's not much we can do. We really want to identify operative lesions, manage the airway, manage increased intracranial pressure, prevent hypoxia or hypercarbia, prevent hypotension, provide adequate sedation or analgesia, because there's really no magic bullet in the emergency department when it comes to more significant traumatic brain injury. But thankfully, those cases tend to be more rare. More typical presentations to the emergency department look like a 4-month-old born in Pittsburgh who falls from her dad's shoulders onto linoleum, has a brief loss of consciousness, but has no symptoms. Or a 9-year-old born in Pittsburgh who gets hit in the face with a baseball bat at recess, has no loss of consciousness, but has headache and vomiting. Or a 15-year-old male who has a head-to-head tackle during contact football, has no loss of consciousness, but has significant amnesia, severe headache, and dizziness. So when we see these patients in the emergency department, we have to decide, do we need to get a CAT scan? Are they safe to go home? And thankfully, there's some evidence to help guide that. I happened to start at the Medical College of Wisconsin at the tail end of the PCARN head injury study, and got to fill out the 10-page packet of clinical predictive guidelines. That study is a seminal study that addressed this issue. They looked at, it was a prospective study of kids under 18. They looked at 42,000 patients. They had to present within 24 hours of blunt head injury and have to have a Glasgow Coma Scale of 14 to 15. And they looked at clinically important traumatic brain injury, which they defined as death, neurosurgery, intubation, or hospital admission greater than 2 nights. They divided them into a derivation and validation set and came up with an elegant set of predictive guidelines. So if you're under 2 and your Glasgow Coma Scale is 14, or you have other signs of altered mental status or palpable skull fracture, you have about a 4% risk of clinically important traumatic brain injury, and a CT would be recommended. On the other hand, if you have an occipital, parietal, temporal scalp hematoma, have a loss of consciousness, have a severe injury mechanism, or your parents didn't think you were acting normal, you got about a 1% risk, and you could observe them for 4 to 6 hours, or you could get a CT scan. And then if you don't have those things, your CT isn't recommended. For kids older than 2, it's pretty similar. A GCS of 14, altered mental status, signs of a basilar skull fracture, 4% risk, get a CAT scan. Loss of consciousness, severe vomiting, severe mechanism of injury, severe headache, 1% risk, observation versus CAT scan. All others, get their discharge papers ready. So we all know, though, a negative CT scan does not equal the absence of intracranial injury. CT scans really address that tip of the iceberg, so kids who are that deaths or hospitalizations. The majority of patients will still have persistent symptoms and functional impairment, and these deficits can really be detected on advanced neuroimaging with biomarkers and with neurocognitive testing. So this is where I had my first bite of the apple. When I started as a fellow, you have to propose a research project. And I proposed to my mentors that I wanted to do this big clinical trial in the emergency department, and they told me I was crazy, which they were right. And they said to take a smaller bite of the apple. So I focused on identifying neurocognitive deficits using IMPACT, which is a computerized neuropsych test. In that study, we had a convenient sample of 60 patients from the ED. They each got a structured assessment and completed a computerized neuropsych test called IMPACT right there in the emergency department. 36 of those patients came back to the emergency department and saw me in an ante room, and we did IMPACT testing again. And then all 60 patients followed up with phone calls at 3 days, 2 weeks, and 6 weeks, and 3 months post-injury. And what we found was that the majority of patients who came to the emergency department had some sort of symptom, either headache, behavioral changes, vision changes, or a sensitivity to light or sound. About 42% of them had amnesia. 27% had loss of consciousness, and 22% had some immediate signs of concussion, either confusion, answering questions slowly, or repeating questions. When it came to the impact testing, all of them had some deficits on the 4 domains that were tested during impact. While the majority of subjects improved in follow-up, the majority still scored well below the 50th percentile for normal non-concussed adolescents. We also found that these patients had significant morbidity with, at 14 days, 50% of the patients reported resolution of their symptoms. And at 1 month, over 20% of the patients had not returned to normal activity. And this is concussion. So concussion is defined as a direct or indirect force through the head or neck or body that causes a trauma-induced alteration of neurologic function. It'll present with signs or symptoms. The typical clinical presentation is a rapid, short-lived impairment, followed by a normal physical exam and normal neuroimaging. This is because it's neurometabolic dysfunction and not structural injury. We used to think that when you had a concussion, the brain was rattling around, but now we know that it's more about rotational forces that occur. This is a finite elements model of the brain and in the skull. And during rotational movements, the brain moves around and experiences shear stresses and strain. When you see red, that's a significant amount of strain, and that strain causes the neurons to depolarize and then become refractory. At the same time, you have a local and global reduction in blood flow to the area of the brain. From animal studies, or I like to call the little bunny foo-foo experiments, you can see that that an area of cortical impact is associated with a decrease in glucose utilization and a localized decrease in cerebral blood flow. This is likely product of evolution to minimize excessive bleeding into the skull, into the intracranial space. But this mismatch is thought to attribute to the concussion symptoms that we see. What's more troubling is that from human PET scan data, this glucose utilization of the brain ends up reducing to match this prolonged cerebral reduction in cerebral blood flow. You can see on the far right, there's this beautiful, normal, rainbow-colored brain, but mild traumatic brain injury and severe brain injury look very similar when it comes to glucose metabolism. So we know these kids, when we send them home, are going to have significant dysfunction and have a possibility of having persistent symptoms. So who should follow up with a specialist? Should they rest or be active after their injury? And where should parents go for their help? Because we know where they're going to end up. So what we know from some seminal work from Jenny Ponsford is that patients and families seen at 1 week post-injury, if given an educational booklet, have less symptoms and less stress 3 months after injury. What we know from data from the TRACK TBI study is that less than half of patients diagnosed with concussion are given concussion discharge instructions. And similarly, less than 44% report seeing a medical practitioner within 3 months, and that includes the 39% that had abnormal CT findings. So we can improve knowledge translation by providing more consistent tools to assess and inform patients seen with concussion. The acute concussion evaluation and care plan was developed by Jerry Joya and our own Mickey Collins, helped to validate a way to identify concussion and provide evidence-based discharge instructions. This is available on the CDC website for now anyway. So in 2009, Noel and I conducted a implementation study of acute concussion evaluation tools and discharge instructions in 2 pediatric EDs, right here at Children's and at Children's National. We convened the Pediatric Emergency Medicine National Expert Panel to adapt the ACE form to an ACE-ED form. We embedded it in the electronic health record. We trained clinicians and nurses in concussion education, and we improved the discharge instructions to emphasize key areas of recovery: resting the brain, providing no additional force to the head of brain during recovery, and managing and facilitating physiologic recovery. This was a prospective observational study with pre and post implementation design. We looked at concussion patients 5 to 22 who were discharged from either of the EDs. We did chart review and patient phone surveys at 1 week, 2 weeks, and 4 weeks post-discharge. And we assessed their follow-up and recovery behaviors. What we found was that after implementation, we saw that we improved the rate of diagnosis and concussion-specific discharge instruction administration. We also had, when we talked to families, they recalled receiving concussion-specific and sport-specific and school-related discharge instructions more after implementation. And we had a 30% increase in follow-up with primary care physicians, from 30% up to 62% post-injury. But we also found that patients reported more symptoms and patients reported a slower return to normal activity. Is this a bad thing? Not necessarily. This may reflect better awareness and closer adherence to guidance. Slow return could be protective, especially in kids, by reducing the risk of second impact syndrome. We know from some studies of catastrophic head injury at high school and college football players that 97% of these occur at the high school level. 60% of these kids had a previous head injury before their catastrophic event, and 71% had that previous injury in the same season. 40% of these kids were playing with residual neurologic symptoms, and this greater than half of these kids had either a debilitating or fatal outcome. We know from animal studies that this is because they have a period of vulnerability. So this mismatch that we talked about before in glucose metabolism and blood flow leads to a period of vulnerability or a metabolic crisis that can last for days to weeks. In this metabolic crisis, you have this window that is where another hit could occur, and that could increase the risk of long-term impairment or death, even if the mouse is wearing a helmet. The risks of exertion during recovery extend from more than just that vulnerability of having a second impact. There is some animal evidence that suggests that early physical and mental exertion could impair healing. And this is thought to be due to the fact that the energy is being being diverted away from the recovering brain. There have been few human studies that have suggested that exertion has negative effects. But one of those studies was actually conducted here at the UPMC Concussion Clinic, and it demonstrates a complex association between post-concussive activity level and outcome. Using a 5-point activity scale coded on chart review, the study found that patients with moderate levels of post-injury activity had the best performance, while patients with the lowest and highest levels of post-injury activity did poorly on follow-up neurocognitive testing. In their discussion, the authors suggested that the patients with the lower activity levels had lower neurocognitive scores because they had more severe concussion to begin with, because it was a retrospective study, we didn't know where they were. And in contrast, they felt that the patients with the highest level of activity may have overexerted themselves, worsening their outcomes. So expert consensus from 2001 to 2022 has really hammered this as far as the acute concussion management. They recommend 24 to 48 hours of rest with a gradual symptom-guided return to light physical activity after 48 hours. But in the past, in the absence of strong evidence, people were leaning into rest as a standard approach. This is from The Onion, but it may sound like satire, but this was actually a real approach that was gaining traction to address the metabolic crisis post-injury. The idea was that total rest could actually help prevent worsening symptoms. So putting the kids in a dark room with no school, no screens, no fun, feeding their meals through a slot in the door. But this was dubbed cocoon therapy. And this is the next big bite of the apple that I took, was looking at whether more strict rest was beneficial after injury. So we conducted a clinical trial in which we randomized patients to either usual care or strict rest. So usual care was no more than 2 days of mandated rest versus strict rest, which is 5 days of mandated rest at home, no school, no work, no activity. And after 5 days, they returned to school and activity when they were asymptomatic. The patients were then discharged from the ED. They completed a diary at 3 days. We followed them up at 3 days, and then they completed another diary, and then we followed them up at 10 days. What we found was that both groups, regardless of what they were assigned, had a 20% decrease in their activity levels in the first 5 days post-injury. But that strict rest group reported less school and less after-school activity for 2 to 5 days post-concussion. But there were no significant differences between the groups on neurocognitive imbalance scores at 3 days and 10 days. What we did find was that the strict rest group reported greater symptoms over the course of the study, which was statistically significant at day 4. It also took them 4 days longer for 50% of the intervention group or strict rest group to report symptom resolution. So what this showed us is that strict activity limits immediately after concussion offered no benefit over the current standard of care, but it did also show us the potential for discharge instructions to influence the perception of illness and symptom reporting. The way we administered this intervention was literally changing the discharge instructions and just handing that to them. There were similar results that were being found in other studies that were published around the same time. My next nibble at the apple was kind of just looking to understand the gap in how activity impacts recovery. So at the time, we knew that symptoms could return or worsen with exertion, either physical or cognitive, but we didn't have much data on how often that happened or how clinically meaningful it was. So we did a secondary analysis of this clinical trial, and our goal was to characterize these symptom spikes. How common are they, when they happen, and whether they signal a setback in the recovery or just part of the normal recovery process. What we found was that a third of patients appeared to be susceptible to high and variable symptom reporting. Interestingly, the symptom spikes were linked to mental activity, but were not linked to physical activity. But the key point is that the spikes didn't delay recovery. It's important because this supports the current clinical guidelines that allow early return to school, light physical activity. Not all symptoms that are mean a setback. It's especially if the patients are more sensitive or aware of how they're feeling. But it does create a problem here. So the current practice guidelines recommend rest for 48 hours, followed by a symptom-guided return to activity. But if we know a third of patients are susceptible to high and variable symptom reporting, they're at risk for self-prescribing prolonged rest, and that may contribute to them perseverating on their symptoms. So we don't want them to self-cocoon. We want to have better advice that we can give them. We have to find the right balance between activity and rest. So there is some potential harm from rest. So physiologically, prolonged rest could cause harm through deconditioning, which may induce physiologic changes in the cerebrovascular control, which may contribute to post-concussion symptoms. As we talked about, cerebral blood flow changes after concussion. Psychologically, you can get harm as rest as a treatment can worsen symptoms through the nocebo effect. If people who take a sugar pill in any kind of clinical trial can report symptoms or side effects. My dad was just on a clinical trial, and he quit the clinical trial because it was causing his stomach to be upset, and it turned out he was on the sugar pill. So physical activity and recovery are also showing to potentially have benefit. In animal studies, they suggested the timing of physical activity was actually critical. Too early, there was no benefit. Delayed, you actually had improved recovery. Previous cohort studies had found increased physical activity was associated with better recovery, but is activity helping people get better, or are people more active because they're already feeling better? There is a large body of literature that's demonstrated no harm or benefits from activity after concussion, and the growing number of clinical trials have shown benefits. Though they were often small, they were clinic-based and focused on sports-related concussion or focused on subacute or chronic recovery. But there was a potential benefit of early prescribed activity, and this is what led to our next study. So this brings us to our latest clinical trial, which hasn't yet to be published, but was just accepted this week. This is the AIM study, Active Injury Management After Pediatric Concussion, in collaboration with Anthony Contos and our team here at Pittsburgh. We tested whether early structured activity management can improve recovery in children with concussion. And this effort was to move beyond that observational data to get some more direct randomized controlled trial data. So this was a multi-site randomized controlled trial that we conducted from 2019 to 2023. Patients had to be 11 to 24 years old who presented to either the ED or concussion clinic within 72 hours of a concussion. The trial was conducted at Children's Wisconsin and here. We excluded patients with conditions that could affect recovery or limit participation, such as moderate or severe traumatic brain injury, developmental disorders, orthopedic injuries, or lack of access to a smartphone, which we'll talk about why, which was required for the study tasks. And then we also had a built-in clinician opt-out option to allow for flexibility for the real world of the emergency department. So we had 4 different treatment groups: rest, mHealth, which is a resilience app, activity, or activity and mHealth, which is with both of those things. So for the rest group and the mHealth group, they were instructed to follow usual care. So that's avoid high-risk activities, rest for 24 to 48 hours, and then follow a symptom-guided return to physical activity. For the activity and M health group, they were instructed to resume low-risk physical activity as soon as possible, to follow specific step-based goals provided for week 1 and week 2 post-injury, specifically trying to get to 10,000 steps a certain number of days in week 1 and a certain number of days in week 2. And we encourage them to push to, but not through their symptoms. And then lastly, the M Health group, and the activity and M Health group used an app called Super Better. Super Better is an app that was designed by someone who suffered from post-concussive syndrome. It's a gamification to promote psychological resilience and recovery. There are power-ups in the game that are quick mood and energy boosts. There are simple actions like drinking water, which I'll take a sip. My mouth is so dry. And quests, which are small, achievable goals that are tied to a broader recovery. And then they also fight bad guys, which are internal obstacles or negative thoughts or self-doubt. The goal was to give participants a tool that actively supported their mental and emotional recovery alongside physical healing, but also the goal was to have a sham non-physical activity intervention. So these interventions were delivered by custom discharge instructions, which were comic-based to help with health literacy. And each of these custom discharge instructions also had an accompanying video to standardize the delivery of discharge instructions across multiple sites. So patients were recruited in the emergency department. They got a Fitbit and an AIM app to measure their daily symptoms. On day 5, we assessed symptoms and mood and somatization. On day 14, participants returned the Fitbit and completed a more detailed in-person and phone assessment, which included symptom scales, quality of life, and optional cognitive and vestibular testing, depending whether they're in person or remote. And at 1 month and 2 months, we follow them up again to assess their long-term recovery, symptoms, mood, activity, and quality of life. We use validated tools across multiple domains, physical, cognitive, emotional, and functional, to get a comprehensive view of recovery. Our outcome measures were related to compliance, which was monitoring their daily step count for the first 7 days using the actigraph, and their achievement of step goals. For the behavioral management or the app, we assessed their weekly resilience scores in the app. And for efficacy, we looked at their symptom burden using the PCSS, their quality of life using the PEDS-QL. For recovery, we looked at the post-concussive symptom score of less than 7, and then their time to achieve that symptom resolution. We also looked at their neurocognitive balance and vestibular, ocular, motor impairment. The original analytic plan was an intention to treat analysis with each of these 4 different groups independently. But then this funny thing happened. So this trial happened in the middle of the COVID pandemic. And so even Santa had to get in the game here. So we had to make a pivot. So post-COVID, we switched from evaluating each of these independently to doing a 2x2 factorial RCT. So we compared rest. So the folks who were told their rest guidance and compared to the activity group versus the folks who did not receive the Super Better app to the folks who received the Super Better app. And we evaluated each factor with no adjustment for multiple comparisons. So we screened 719 patients for eligibility at our sites. Of those, 480 were excluded, mostly due to declining to participate in this mad science experiment and not meeting inclusion criteria. So the common reasons included admission, pre-existing conditions, or additional injuries that limited activity, or they didn't have a smartphone. We successfully randomized 239 participants into the 4 groups, and each group had around 60 participants with minimal drop-off after randomization. Most of the participants, about 85%, were recruited from the pediatric EDs. The sample was balanced by gender, around 50%, and predominantly white, roughly 75%. The average age was 14.5 years. The most common injury mechanism was sports, followed by falls. Importantly, there were no clinically meaningful differences between the groups at baseline, whether it was symptom severity, injury details, prior concussion, or ED treatment. Follow-up rates were really strong, 91% at 14 days, 88% at 1 month, and 81% at 2 months. When it came to compliance, the activity group did what we asked. They moved more. So the first week, they averaged about 7,000 steps per day compared to 5,700 in the rest group, which is statistically significant. They were also more likely to hit that 10,000 step goal at least 3 out of the 7 days, 38% in the activity group and 12% in the rest group. The mHealth group engaged with the app as intended and interacted for a median of 5 days. About half of them met their resilience score goals at week 1 and week 2. So overall, we had pretty decent adherence, though hitting those step goals 38% isn't great, but it was different than the rest group. But we found no difference in primary outcomes when it came to post-concussive symptom disorders and PEDS quality of life at 14 days. Participants prescribed the rest group had fewer mean balance errors at 14 days. There was no difference in secondary outcomes between activity in the rest group, but there was a difference in symptom trajectory. When we looked at symptoms over time, the activity group had a higher post-concussive symptom score during the first 7 days, and that difference was no longer statistically significant at 14 days. We found it took the activity group about 5 days longer to reach symptom resolution, defined as a post-concussive symptom score of less than 7, and compared to the rest group, and that difference was also statistically significant. So while overall outcomes at 14 days were similar, the early activity group may have modestly delayed their symptom recovery. We found no significant differences in primary or secondary outcome or symptom trajectory with the app. So really, early prescribed activity was associated with early symptoms and slower median recovery. This conflicts with the results of previous cohort studies and other recent clinical trials. It's clear that the timing, population, and intervention rigor may influence their outcomes. When we talk about intervention rigor, I'll focus on the work of John Leddy in Buffalo. He's conducted multiple RCTs, which have shown faster recovery with an individualized sub-symptom threshold aerobic exercise compared to, in this study, stretching. This was a clinic-based RCT that the activity was tightly calibrated and tailored to each patient's tolerance level and guided by a targeted heart rate, which they use by using the Buffalo treadmill test. So they do a treadmill, see when the symptoms occur, and then dial down it based on your heart rate. Our intervention was pragmatic. We can't do that in the ED. I can't get somebody on a treadmill in the ED. That would be ridiculous. Everyone would get mad at me. So it was designed for the real world, but it wasn't really personalized to the same degree. And this difference in approach and standardized versus individualized may explain the variation in results. In a more similar trial conducted in Canada, the ED-based RCT, which was more similar to our intervention in that they were looking at resuming physical activity at 72 hours regardless of symptoms versus that symptom-guided return to activity, they also found no significant difference at 2 weeks. But in their per-protocol analysis, patients who were adherent to the early physical activity had fewer symptoms. So exercise is medicine, but the dosage matters. So not all activity is created equal. Exercise must be tailored, timed, and titrated. There's early generic activity, which is what we did, versus a structured symptom-guided exercise. So timing is everything. So too much rest or too much exercise early without accounting for symptoms may delay recovery and cause harm. So the clinical implications support the usual care. So this is moving from expert guidance to evidence-based medicine. So prolonged rest is associated with worse symptoms. Early activity without consideration of symptoms is associated with slower recovery. And symptom-guided return to activity leads to faster resolution. This individualized approach is needed to prevent excessive rest or premature activity. So for me, our ED-based clinical trials, whether strict rest, early activity, or this mHealth app, showed no benefit or no clear clinical benefit beyond usual care. At this point, I'm starting to think the universe is telling me it's time to move on. So usual care remains the best care. So what matters more is accurate diagnosis, targeted referrals to the primary care or specialty care to support recovery, and identifying barriers and facilitators to that follow-up concussion care. And that's an ongoing study that we're looking at using qualitative methods. I'm now refocusing more on preschool-age children to study biomarkers and developmental impacts of concussion in vulnerable populations, and I'll present a little bit of what I'm interested in doing next. So we're focused on 3 of the most studied blood biomarkers, and these blood biomarkers have been validated in adults. There's S100B, GFAP, and UCHL1. These are proteins that are released into the bloodstream when the brain cells are damaged. Their levels in adults can correlate with injury severity and may help to distinguish mild from more severe traumatic brain injury. Clinically, they're useful because they're non-invasive and can complement imaging, especially when the CT isn't clearly indicated or looks normal. But there's a key challenge when it comes to pediatrics, and these markers are mostly validated in adults. Children's brains, as we know, are developing, and their biomarker levels may vary by age. So adult cutoffs may not apply, which is why we need a pediatric-specific thresholds before we're able to use these in our clinical practice. In some work I was able to do with Rebecca Mannix, we looked at blood from 360 healthy kids from 3 months to 18 years, and we looked at GFAP and UCHL1 in a biobank of samples that they had. What we found is that UCHL1 was stable across ages, but GFAP showed a clear age dependence with levels higher in younger children that dropped off by age. In fact, 20% of the kids exceeded the adult threshold, with 100% of the kids exceeding the threshold if they were under 3.5. So the bottom line is using these adult cutoffs could lead to false positives. So we need to age-adjusted thresholds before we can start using these in a clinically meaningful way in pediatrics. There's another promising area of biomarkers is salivary microRNA. These are small stable molecules that are involved in gene regulation, and they're detected in the saliva and may help to reflect brain injury process. We've seen changes with these microRNAs within minutes after head impact. They've shown an association with more severe injury. They can distinguish concussed from non-concussed kids, and they can predict prolonged symptoms. So they're still early in the work, but microRNA are often this non-invasive, developmentally sensitive tool that I'm drooling over. Okay, and then finally, post-concussive problems in kids. We often think of preschoolers bouncing back very quickly, but a review says otherwise. There's systemic reviews that have looked at 11 longitudinal studies of kids age 2 to 5. While acute symptoms recover in the vast majority, there's 18% of kids at 3 months that have challenges like sleep problems, mood problems, or appetite changes. And then at 6 months, at 6% are symptomatic a year later, experiencing irritability, personality changes, sensory issues. So even in young kids, concussion can have these lasting effects, and we need better tools to manage that or understand the developmental trajectory impact. So in conclusion, the findings of this show that concussion is a functional injury and not always visible on imaging, but it's very real. Too much rest can delay recovery, but unstructured activity too early can also worsen symptoms. Discharge instructions matter. A clear plan helps patients and families support recovery and follow up appropriately. The best path, I suggest the Goldilocks approach. So rest briefly, then begin a gradual, individualized, symptom-guided return to activity. Not too fast, not too slow, just right. I'd like to thank my mentors and collaborators, both here in Pittsburgh and in Milwaukee. I'd like to specifically call out the CDC TBI team, Donna Waltzman and Julia Harbor-Krupa, for their hard work and dedication in helping us navigate a clinical trial through the pandemic. And with that, I'm open to questions.